but we stand ready to answer any questions. There was a request to change the order and to start with the Meadows report, and so we have a great team assembled to talk about the findings from the report and some of the initial recommendations, and I'm going to turn it over to Assistant City Manager Ray Ariano to introduce this.
Thank you, City Manager. Mayor Pro Tem and council members, again, Ray Ariano, Assistant City Manager. It's our pleasure to provide an update on the first responder mental health calls for service. By way of background, in the current fiscal year, council set aside a funding amount in order to study what system improvements that we can make that will ensure that in an incident involving an individual in mental health crisis, Austin's first responders will ensure that individual receives clinical care as quickly as possible, thereby ensuring the safety and security of the individual and the community. Staff engaged the Meadows Mental Health Policy Institute in order to conduct that study. And with me here today is BJ Wagner, who was the lead consultant on the study, who will provide an overview of the approach and the recommendations that came of the study. Also with me here today is Assistant Chief Justin Newsom, Austin Police Department, as well as Don Hanley, Chief Operating Officer from Integral Care, who will, as well as Assistant Chief Andy Hoffmeister from EMS. Those individuals provide an update on piloting or implementing the recommendations. And I also want to recognize in the audience Karen Reynes, who is the Executive Director of Central Texas National Alliance of Mental Illness. And with that, let me turn it over to BJ Wagner.
Good morning, and you told me to remember that too. Good morning, and thank you for the opportunity to provide you with this overview. I'll keep my comments as brief as possible to ensure that you can get the meat of what's happening now from the other folks here today. But as you know, with Austin being one of the country's fastest growing metropolitan regions, you guys have some special challenges on your hand that most city leaders don't face. Some of those challenges include ensuring that your public safety systems are effective, efficient, and well equipped to meet the needs of those who call Austin home. During our engagement with the city, we utilized the proven data and systems analysis methods to ensure that we could provide you with a tool to do just that. Our recommendations are based on published and empirical research, but deeper than that, this research and evidence-based practices and programs all have proven outcomes that match the variables that are specific to Austin. It is a data-informed, research-driven, tailor-made map of improvement for the city of Austin. To get here, we pulled calls for service from APD that had any element of a mental health indicator, even if that indicator was evident when the call was complete. We then did the same for EMS services. Next, we reviewed Integral Care Crisis Hotline aggregate data, as well as MCOT and EMCOT aggregate data. And lastly, we pulled calls for service with mental health indicators that had a response to resistance intervention, commonly referred to as a use of force intervention. We did this for a 3-year span and matched all data sets to find commonalities. Finally, we overlaid these data into city demographic data, including socioeconomic status, racial and ethnic demographics. And even though we don't have time to review all of our findings here today, you can find these specifics broken down into graphic maps in your report by APD patrol district as well as by your city council districts. I'll focus on a few recommendations today due to time, not all of them, but the first set of recommendations go hand in hand. So if you will, please refer to recommendations number 2 and 3. Evidence from programs across Texas and across the country show that integrating clinical triage at the earliest point of 911 reduces the inappropriate allocation of public safety resources to address healthcare needs. But also, there were several cases reviewed during our engagement in which an officer was never informed the call he was answering was a call with a strong mental health component and a crisis unfolding. This left officers without the tools and information that they needed, and these calls unfortunately resulted in the use of deadly force. Although it is unfair to say that these two issues are causational, as a matter of fact, APD has one of the lowest use of force rates for mental health calls for service than any department in the country. It is equally as unfortunate to not provide the department with the tools it needs to address mental health crises in a modern policing framework while expecting modern policing outcomes. To do this, many communities across the country are adding clinical triage to 911 systems, either through the use of a virtual clinician or by adding clinical staff to the call center. This develops the ability to divert calls to more appropriate resources, But most importantly, it also develops the ability to provide officers and medics on scene with critical information that they need to be able to manage that call efficiently, effectively, and safely. This effort has saved Houston literally millions of dollars in public safety resources over the past 5 years, and Dallas, a much younger program, hundreds of staff hours while providing critical connections to care at a most vulnerable time. The City of Austin should collaborate with Integral Care to place clinicians directly on the dispatch floor as an integrated component of 911 operations, but that's not enough by itself. Clinicians don't answer 911. Call takers do. So providing call takers with the highest level of training possible to recognize a caller experiencing a behavioral health situation will ensure that they can properly route the caller to a clinician. You'll find greater detail in the full report. But now let's refer to recommendations number 4 and 5. There's also an additional large body of evidence supporting mobile telehealth as a workforce multiplier, making it possible to immediately connect people to crisis and health services at a time where it's needed most. Telehealth is not intended for instances of immediate risk to public safety or volatile calls. However, overwhelmingly, the mental health calls for service, APD, and Austin EMS are answering do not fall into this range. Yet without immediate care connections, people are unlikely to be connected to care at the moment of that crisis episode. They have an elevated risk of arrest and a perpetuated cycle of crisis, which can, after time, lead to a more volatile outcome when needs go unmet for a long period of time. MCOT does a fantastic job of diverting people into care and should be supported, but it is not practical or financially sustainable to hire enough MCOT clinicians to answer each call. In-person contact should be utilized for those most in need, and telehealth for low-risk calls, thus maximizing EMCOT's in-person reach to address those who need it most while providing a more comprehensive coverage for mental health calls for service through EMCOT telehealth. In the recommendations section, you'll find statistics related to savings and positive outcomes when this approach is used. Full implementation of this recommendation is key to any anticipated outcome or impact. The recommendation for targeted expansion of telehealth in specific areas of the city includes telehealth capacity for community paramedics and EMS as well. There is a growing body of research that supports a vast reduction in chronic crisis by integrating paramedicine support appropriately into a co-response with mental health officers. As a matter of fact, this multidisciplinary model was just recognized and awarded by the International City and County Management Association in Dallas, invited to present at the International Association of Chiefs of Police, recognized by Results for America, and heralded by the State Department for its impact on reducing quality of life crimes, including those related to substance use and abuse. Integral Care and APD should be commended for their movement forward. Austin is at a perfect place to demonstrate impact on vulnerable populations, and through the creation of a truly unique continuous system of prevention that is specific to your city, this response could lay the foundation for a model system for the rest of the state and country to look to. I encourage you to read the full report, consider what different would look like in Austin, and I'm happy to answer any questions you may have.
Thank you, BJ. And
Go ahead.
okay, and so what I'd like to do now is go through each of those recommendations and have staff provide an update on what we're doing. So this is the first of the recommendations, and for this I'd turn to Assistant Chief Newsom.
Good morning, all. So the first I'm sorry. I did it too. The first recommendation being to form an advisory board for the Travis County Behavioral Health and Criminal Justice Advisory Committee. We're long members of that committee. We've been on it for a number of years, and so this was actually a fairly easy one for us to accomplish. On the 9th of August, I briefed the report to the committee and asked for feedback and thoughts and planning going forward of how we can report to that committee and get feedback back from them as ways to improve our response to mental health calls. And we expect to have that first report to them by the fourth quarter of 2019 this year. Mental health training for call takers. Currently, all of the 911 call takers that answer 911 calls, they're APD employees, they all receive the state-mandated TCOL training on basic telecommunications and also crisis communications. Currently, that curriculum is being updated by the state. It should be finished in mid-2020. I had my staff in the CIT unit, along with Integral Care, review that training. We did find some of the the gaps that Meadows recommended that we train to, and so we're currently working on improving that curriculum to ensure that the recommendations by Meadows are incorporated in the training. Mental health integrated dispatch. Actually, Dawn and I had begun a conversation on this prior to this process even beginning, prior to even hiring Meadows. We've been talking about this for some time. It's been a big goal for both of us for a number of years, actually. So we're currently amending the workspace there in CTEC. There's no extra space there, so we have to move some people around and create physical space for those clinicians to be. We're hoping through this funding process that EMCOT is able to sustain their current operations and hopefully increase their operations. And Dawn and I and others on both of our staffs have been talking about training needs and developing procedures of how that would actually work. It's something brand new. There's not really a model that we can look to that's plug and play, and so we have to develop all of that as we go. First steps being getting that space done and getting the positions funded. Again, sustainability of EMCOT. EMCOT is extremely vital and truly the foundation of everything that we do as public safety professionals in Austin in relation to the mentally ill community. I don't know what we would do without EMCOT and integral care. We started a pilot already, a telehealth pilot, using iPads that were provided for by integral care that they had. We have a group of officers who are actually working in District 7, being that it's the farthest away from the center of the city and the hardest for EMCOT clinicians to get to. We thought we'd start it there just for practical reasons. We started it August 1st. We've had a handful of uses of it. We're still working through some kinks and some procedures to make sure that we can continue it. At the end of this month, here this week, we're going to evaluate what we have done, see where we need to tweak it, and see where we need to move it to so that we can scale it up and expand it. Collaboration with EMS's community health paramedic between APD Crisis Intervention Team and them. To begin that effort, we actually moved the homeless outreach street team officers under the supervision of the sergeant of the APD Crisis Intervention Team so that there's some natural co-efforts that are undergone there. We have a great relationship already with EMS and the community health paramedics, and so again, that's not a heavy lift for us to collaborate more with them in response to people who are mentally ill when it's appropriate. We've also amended our procedures in a crisis intervention team so that it's required now that all referrals, and we've been doing this for some time, but we didn't as definitively say it's required until recently, that any follow-up that's done by my officers in the crisis intervention team will be done in conjunction with EMCOT. And so officers will not go out and do follow-ups on their own to a person's house without taking a clinician with them or a paramedic if that situation is indicated. And community outreach and collaboration with NAMI Central Texas. Again, we have a long-standing relationship with NAMI. In 2014, we created and APD funded some information that we gave out to the families of people who are experiencing mental illness through NAMI, explaining what to do when you call 911. If you're calling 911 for your loved one who's in a mental health crisis, what do you do? And so we developed that material back in 2014. We've now translated that into both Spanish and Vietnamese. We're working through our Office of Community Liaison. We already have established relationships in both of those communities, and so we're gonna weave into those presentations and those forums that we go to, training with NAMI, with materials in their native language, so that we can educate both of those populations better on how to call 911 whenever you need the police there or someone there for a loved one in mental health crisis.
Okay, and with that, we're available for any questions you may have. Thank you.
Councilmember Kitchen?
Okay. I have a couple of questions, and so I'll ask a few, and then if others want to ask. So let me start with, the recommendation related to the clinicians, which I think is, forget which number recommendation that is.
Number 3.
So I'd like to ask, and that's recommendation 3, I believe, which is the mental health integrated dispatch, to have a clinician embedded in that. So that I'm seeing here, I believe that that's unfunded at the moment. So, but it sounds to me, and first off, let me just say, I should start with this. I really appreciate everyone being involved in this. I think it's just another opportunity to improve on on the work that we do, and make our approach even better.
Mm-hmm.
So I appreciate
Agreed.
that, and I want to thank the Meadows Foundation and BJ for working with us on this. So I wanted to hone in and ask my questions first about the clinician positions. So it seems to me that that's a critical aspect of the change here, and so I would ask you all. I see that it's not included. Is that a budget issue, or do you all have concerns about including it? It sounded to me like, from what you were saying, that you felt like this was a good recommendation to move forward with. Did I hear that correctly?
Absolutely.
Okay, and so if we put that money in the budget, is that something that you all would think was a positive thing to proceed with?
Yeah, and I'll defer to Dawn on that question, but the plan was to use current EMCOT staffing that responds to calls, to rotate them through as the clinician. But the best practice would be to add additional clinicians to EMCOT so that you're not taking from existing resources. I'll defer to
Right.
Dawn.
Hi, Dawn Hanley, Chief Operations Officer, Integral Care. Thank you for the opportunity to speak. I believe that I heard last year when we were before council that really the focus was upstream. How far upstream could we go to make sure that we were having the appropriate people available for individuals in the community who were experiencing a crisis? This, I think, meets that need. This is how individuals are accessing the first responder system. It goes through the call center, and the call center does the triage to determine, is it fire, is it EMS, is it APD? So if we're able to add a component, is this a mental health call, and work with training them on some risk stratification and ways to identify that individuals may not express at the time that they're calling, but for them to be able to suss that out, if you will, and hand it to the clinician on the floor. In my mind, this is a fully integrated system, and when we look at healthcare in general, we're looking at opportunities on how we can integrate care, right? Primary care, substance use, and mental health services. This, in my mind, is just an extension of that delivery system. We're fully integrating the mental health clinicians on the floor of the call center where that crisis is being reported. And so if they could do a direct handoff to us, then we have access to our records. We can see if they're already open for services. We can dispatch their current care team when that's appropriate, and not even dispatch a first responder at all, which would be optimal. There will be instances where you have to do that, just by the way that our law here in Texas is structured. If somebody needs an involuntary admission, only law enforcement can provide that. So that, they have to go at some of those times. There might be other times when someone's on a call, or EMS even has a call, and they're thinking there might be a mental health issue involved. And if you're on the floor, you can have that conversation right there in real time and make a determination: is that us? Is that you? Is that us together? So I think this is a valuable tool. Like Justin mentioned, we've really been talking about how to make that happen. But if we want to do it well, we need to resource it. We were looking at how, based on these recommendations and this opportunity to kind of look at our system, and through some of the data that Meadows was able to gather for us and analyze, it really kind of supports that effort on that further upstream practice. So we were just looking at ways we could do it with what we had, but that does take away from another resource. So if we're using the existing mobile team to fully staff this, then you lose some of your capability and availability in the field to go on a call. And I think you also saw in the report that there were some identified gaps where we weren't available. That's because we're not staffed 24/7. We're not funded to be staffed that full amount of time. So those are some gaps just in the existing system. So in
Okay.
my mind, this would be additive to that foundation that we've already started.
Okay, then my last question related to that, I'd just like to ask BJ if she wants to come up and just tell us any more about sort of best practices related to the clinicians and other, embedding the clinicians that might be. It sounds to me like everyone is talking about this being a valuable thing to include. I just want to understand if there's anything you would like to add about why this recommendation is so important.
Absolutely. When we look at call centers, the findings are very similar to what we find here in Austin, and it's that the dispatchers receive the minimal amount of training required, and that's funded or sponsored by TCOL, and it doesn't really cover the kinds of things that a dispatcher would need to be able to efficiently and effectively identify a mental health call and then manage it. Even if a call taker can identify a mental health call, they'll never be a clinician. So that management piece is always going to be how quickly they can get off of that call, get it dispatched, and get it out to someone else. And that, again, it's not specific to Austin. It really is just the function of the call center. But when you look at call centers that have clinicians infused, the first thing that's important that they do is ensure that there is data sharing. That call center clinician needs to have access, like Dawn was saying, to the data that is coming from the local mental health authority or from their provider authority so that they can do some immediate clinical triage based on that client's need and client service. But then they also need to have the options to determine where that call needs to go. The goal is not just to make sure that they're sending it out to a police officer with really good information, but it might need an alternative response. So there should be a well-vetted, safety-tested call tree to ensure that these clinicians have access and resources on where else to send that call. But most importantly, I encourage you to look at the data in your call center and determine the best times for a clinician to be there. I always tell communities that we're working in, don't spend money you don't have to spend. Look and see when you need someone, whether it's the day of the week, the time of the day, or even seasonally, and ensure that you staff appropriate for what the data is telling you, and don't apply a resource to an area where you really don't need it, and save those resources for other places. But in the recommendation section, you can see where these clinical call centers are happening. It's saving Houston $1.3 million in their first year. It has saved Dallas hundreds of man hours in the first 6 months of their operations. So they really are truly effective.
Okay, thank you. I have other questions, but I'll defer to someone else.
Can I ask just one clarification on the papers in front of us? We have two papers in front of us, and they don't seem to match up in their recommendations. Can you just explain with this paper?
These, I don't know what papers you have in front of you. You have that paper and what else?
Just the slides.
Oh, the paper that you have in front of you that is the narrative, that's...
You're on.
Okay, so usually my voice is loud enough. I don't need a microphone. But the paper that you have in front of you that is just the narrative, that is the recommendations pulled directly from our report. The PowerPoint, I believe, is the city's current status of where they are with those recommendations.
Thank you.
Councilmember Flanagan?
A couple of quick questions. Can you give me a little more detail on the funding split between the city and Travis County?
So I'll start that. I believe it's a 60-40 split. So of the total 1.8, 60% of that cost is covered by the city, and 40% of that cost is covered by the county. And if you look at the data on use of referrals, the city utilizes our resource more than the county does.
And one of the concerns that my constituents have is that when they call 911 on the edge or in Williamson County, sometimes they're not going to the same call center. And so I'm concerned about myself, frankly, living in Williamson County and the 45,000 folks that live with me out there. And the relationship with the Travis County Health and Justice Committee. How are we ensuring that all of Austin's taxpayers are getting this same service?
So if you call 911 from that location, you're still in City of Austin jurisdiction, and still our officers responding. We still have the same collaboration with MCOT. You know, and if they don't respond to the scene and a report is written, we can still refer it, you know, to ensure that the person is followed up with to some degree. But, you know, I'll have to ask Dawn to speak to how they interact with Williamson County and their counterparts.
That's an excellent
Location.
question. Thank you for asking. We actually do have agreements with the other local mental health authorities where there's contiguous boundaries. And so we're a strong partner with Bluebonnet, which serves that area. And oftentimes people live kind of right on the line, so it depends where they go. So if they want to receive services in Austin, we do pick them up even if they have a Williamson County address and vice versa.
That's good to know. The host team said it was moved under APD. Is that
Well,
right?
the host officers, you know, we have 2 host officers who are part of that team. They've always been under APD, but they were under
Sure.
the downtown area command. We
So it's
moved
just
it
a shift internal within
internally,
APD.
so
Okay.
that they're
Sounded
naturally
like a bigger change than.
no, sir.
Got it.
So that
Okay.
they're naturally aligned with the crisis intervention team now.
Thank you.
And council member, if I may add, administratively, EMS provides the administrative oversight and management, if you will, of the host team as a unit. And again, it's APD, EMS, community court in terms of services, and integral care for the case manager.
Yeah, I mean, one of my ongoing concerns and work that we'll do even past this budget is ensuring that we're maximizing insurance reimbursements. So things that EMS can get reimbursed for insurance, but APD or fire can't, and ensuring that we're maximizing that type of opportunity.
Thank you.
Councilor Alter, did you have a question?
I did.
Okay, go ahead.
Thank you. I wanted to better understand if there's an additional ask for resources for making the call center respond to police, fire, EMS, and mental health. As I understand it, that was one of the recommendations, but I'm not seeing what the budget implications would be of that or a discussion of that in here. I missed it.
Can I start and then
Sure.
hand off to Dawn? The recommendation for asking, do you need police, fire, EMS, or mental health was inspired actually by Dawn Hanley. And when we had that conversation, we took it and took a statewide blanket look to it to determine, is that something that's feasible? And I spoke with about 40 police chiefs across the state and a couple of sheriffs and asked them, what do you think about this? And the overwhelming feedback I got was, we're already doing it. Your police department's already responding to those mental health calls. They're just not asking that question when somebody answers the phone. So it's not actually adding on an additional duty. It, again, is just moving that triage to the earliest point possible. I mean, can you imagine being in a place where your loved one is in a very vulnerable state and you're scared and your loved one is scared and you call 911 and suddenly they're asking you, do you need mental health? What an overwhelmingly affirmation that could be to somebody who needs help. And it, like I said, it was inspired by Dawn.
Joint effort. Thank you, BJ. But I think if I'm understanding your question correctly, is why are you not seeing this recommendations funding moving forward in the budget? Asking, and I think we have to defer to Ray to answer that question, like how it moves forward. As a service provider, we fully support it. APD and EMS are fully in support, but I think there's a finite amount of funds to use for this service delivery, and that's a recommendation to bring that to fruition that's beyond our scope of influence.
And so in follow-on to that, essentially the protocol that you described would be included under this particular item to integrate a clinician on the call center. And so they would develop, and in fact, to some degree, when they get to that point and have the equipment set up and so forth, they'll begin to figure out what that question tree looks like, which could include the addition of a mental health service in that call tree. The reason why it's not included is because there was a desire, certainly in proposing it to the city manager's budget, that we try to figure out what we actually need, what are the lessons learned, what can we leverage by current assets and the partnerships that we have prior to coming forward with a budget ask. Clearly, as was described by Ms. Handley, in order to keep the resources that we currently have doing active in-person call support for APD officers or EMS for that matter, the recommendation would then be the two positions and the 300K that you see here.
So in order to get to the point where we can innovate and do that, we first need to have these two mental health positions, and they would be working out the protocols, because if you ask that question and you get the answer mental health and you've nowhere to send them, it doesn't do any good. Is that, I mean, I'm just saying that it seems like there's a sequence here, and that it is the city manager's office intention to be proceeding towards developing that, or, I mean, I'm just trying to understand if we need to give direction or if it's already the path that you have chosen to move forward with.
So it's, and I can defer to the experts that are actually doing this, but it's our intent to actually to construct the protocols, see what's required, the script, if it needs to be changed, what needs to be changed about the script in order to get to that point where you can do a dispatch, which can be done with existing resources. Once we get there, we could again do it with existing resources. However, the implication is the two clinicians that might actually be able to respond with calls, on calls with officers, are maybe in the call center in order to do the work. So again, it was an intent to try to put things in place, the processes and so forth, the equipment that's necessary, and then to see how many resources in some future budget that we might be able to then bring on once we have that experience. Clearly, again, we understand here that it would be $300,000 in order to add the clinicians at some later point, whenever that might be, in order to have the full capability or maintain the full capability of EMCOT out in the field.
Thank you. Last night at the budget hearing, we heard from someone from the call center raising some questions about some staffing issues. This is probably not the appropriate place to get full detail. I just want to flag that I would like to understand better that choice of perhaps letting go of experienced, trained folks who are at 30 hours in favor of vacant positions, and understand what's actually in the budget in that regard. So if we can follow up on that, I would appreciate it. There's also been discussion that we've heard about additional paramedics. How does that fit into this discussion, and what is staff's recommendation with regards to that?
And so, could you be more specific? Because there were a number of recommendations that were discussed at last night's budget hearing.
I don't have all of the details at this point. I think it was on the order of 8 to 10 additional community health paramedics.
And so I can ask Assistant Chief Hoffmeister to perhaps come and talk about this community health paramedic program that we have. Certainly they can contribute in the ways that they're currently operating, providing medical services short of pre-hospital, taking individuals to the emergency room. They can certainly be a participant in the host team operations. In terms of them, if I'm understanding where you're headed on this, in terms of them being the clinician that accompanies an APD officer to the scene, providing that mental health capability, we would recommend that it's Integral Health that has clinicians that are trained in this regard. That might be the appropriate resource to send rather than a paramedic.
Thank you. I'm just trying to understand. We have a lot of, I think we need to invest more in mental health, and we have to make some choices. And so I'm trying to understand the different choices with the limited information that we have. And I guess it's 6 additional that they were asking for, but please go ahead.
So Andy Hoffmeister, Assistant Chief with EMS. So yeah, we've heard and we understand that there are requests for community health paramedics. As it relates, and I'm going to just speak just primarily to the mental health discussion, the current team, we can allocate, there can be times when we can support APD and integral care in whatever need that they may have. Now, additional resources, if they were to become 24/7, right now they work primarily during the day on weekends and weekdays. They are a kind of a multi-mission resource within our department that can focus on some of the specific needs, especially mental health. We work very closely with integral care and APD's CIT team. So it's just a matter of how you want to scale or how this would be scaled up in terms of the exact number of staff. Those CHPs could also be utilized for things like homeless outreach or any other non-urgent, non-emergent needs. And they could also serve as first response for, the more urgent needs where there's a time-sensitive intervention that's necessary on scene.
And what is the estimated budget implication for each CHP?
Each CHP, initially, I'd have to look at the exact numbers. You're probably looking, I'm not exactly sure, but somewhere around the $200,000, $250,000 range to fully equip both personnel and equipment. Now, ongoing costs would be personnel and supplies and consumables in that context.
And we can get that information afterwards.
Great, thank you.
Councilor Kassar?
So I have 3 questions, and I'll probably need BJ up here, but also don't want to lose any of you all. So I don't know however you want to sort it out. I want to drill in on the 911 call taking questions to just follow up on the useful questions that were asked. Then I want to drill down in some of the community health paramedic stuff, and then third, ask about the distinction between first and second mental response versus second response to mental health stuff. So first, on the 911 call takers issue, it would be really helpful for me to understand. On your slides, it has here that, and maybe Ms. Wagner, you can help me with this, that what we currently are doing should, without any budget impact, should be able to train everybody up. Is that right? We don't have, or is the current implication that we don't have to allocate more resources in this budget in order to achieve the Meadows recommended level of training for 911 call takers? Or is it that's the training side, and then I recognize that there's also staffing on the clinicians in the 911 call taking. But on training, are we covered with what we're planning on currently doing without making any budget changes?
You'll see in my recommendations that there is a budget impact to the training because we recommended the development of an enhanced training beyond what TCOL is providing. For instance, Chicago Police Department partnered with their local NAMI and other mental health providers to develop a comprehensive crisis training specific to a 911 call center that better equipped their call takers to be able to manage, identify, and triage these calls. And it's phenomenal. But they had to spend some staff hours doing that. So there's some budget considerations in my recommendations for perhaps consulting contract with Integral Care or your provider of choice to help develop that training. But then also I think you'd have to consider overtime if you wanted to ensure everybody was trained in the 12 months. There's going to be some overtime expenses for folks filling the gaps while your call takers are in training.
And so I totally understand and respect staff putting together the training that they can based on the budget that we have. But do we have consensus amongst staff and Meadows about how much it would cost to get people trained to the levels that Meadows actually recommended within a year? Is there
We don't
consensus
have
about how much that
we don't
costs?
have calculations for that, but Ms. Wagner speaks of Chicago contracting with NAMI. We already have such a relationship with Integral Care and NAMI that their work on this will be at no cost to us. They do 80% of our training for officers already. And so we won't have to pay to get anybody to help develop that training. There absolutely will be overtime costs associated. It's kind of hard to figure that, of when you'll have to move people off the consoles and schedule classes and backfill their positions. But as far as just spending money to develop the training, we can do that at no cost. It's just implementing it and having people pulled off the console will cost money at some point.
And we'll decide. We'll have to make a call on dollars here shortly. What it would just be really useful is if y'all could huddle and the manager could tell us, okay, if there's any disagreement, this is what it is. If there's a cost, whether the manager recommends we include it in the budget or not, this is what it is, just so that we can make a judgment call one way or the other. It sounds like you're really close, but if one of y'all thinks it might cost us and one of y'all thinks it might not, it'd be great just to understand what that difference is so that we can either put the money in to be safe, or we can say, hey, actually, we have the relationships that it won't cost us, which is great.
Right.
We're always happy to hear that, but I don't want to go that way just because it's easier.
Sure.
It's of course easier on me to say, well, we've got it covered. But if So if y'all could work that out for us, that would be helpful. And then so the other recommendation, it seemed to me, was about clinicians being in 911. And what you're saying, Assistant City Manager, is that it might take us some time before we bring those folks on. Is that right?
That's right. Time in terms of being able to put the protocols and equipment in place. And then at some point, for integral care to bring on additional clinicians that aren't currently hired and so forth. So just based on that and trying to properly scale and be thoughtful about the expenditure that we might bring forward, that was the approach that we recommend coming forward.
And in the Meadows recommendations, is that recommended to be done at the same time as this training is happening, or is it afterwards? Would it be within this fiscal year that we bring those clinicians on? Would it be possible, if there were the funding, to bring those clinicians on, or does it make sense for it to be in a separate fiscal year?
Actually, you guys would be the only city that trained their dispatchers in collaboration with the clinical triage being in dispatch. Houston, Dallas, and Abilene all integrated the clinical dispatch piece and then later trained their call takers. And it's a lesson learned experience that training is important. But the training isn't critical to the function of the clinician being there. It enhances it, and it's important. But you could certainly have your clinicians in dispatch while you were developing the training, and they may actually become a very important part of informing what that training should include.
And so your recommendation might be that we bring those clinicians on sooner rather than later.
I think the clinician present in dispatch is one of the most critical things that the city could do.
And so one of the most critical things in your view, which of course we can disagree about, and there's 11 of us here and we vote, but in your view, one of the most critical things we could do is actually to have the funding available to bring clinicians on as soon as we can.
Absolutely.
And
Absolutely.
currently, the city manager's estimate is about $300,000 for that.
Yes.
Okay, and that's currently not in the budget, but could be something we work on if it makes sense.
Yes.
Okay, great. Then my second question was on the community health paramedic side. In the Meadows report, or is it a Meadows recommendation, or I forget if it might have been a community idea for the Chief Ostmeister, of course, you're welcome to chip in. Don't push the microphone away so fast. Is it a Meadows recommendation, or I forget it, or if it was a community recommendation to have the CHPs do follow-up on mental health calls? Is there a reason or a distinction for it to be EMCOT versus CHPs versus whoever else? I think there was a desire to see CHPs proactively addressing issues in the community, as they already are, but then also potentially for them to be doing some of the follow-up, which I think was in Meadows, but now I feel like I might.
You're right, and I'll keep this brief so that Andy can take it from there, but our recommendation was to have that paramedicine presence, and it's because the paramedicine presence is vastly different than an EMCOT clinician. The EMCOT clinician is going to focus strictly on that behavioral health clinical need and addressing that need. But what we have seen in this population is that the comorbidity is very high with chronic disease rates and people who have significant behavioral health care needs. And if you're just solving one problem, if you're just addressing the mental health need and getting them to a doctor and giving them mental health medicine, but you're not addressing that chronic disease process that's comorbid with that, you're not reducing your crisis cycle. Every successful program that shows a reduction in repeat calls for crisis includes a medical component, and the best way to do that is through paramedicine.
And that would be in follow-ups to the mental health calls themselves.
When we looked at the data, EMS and APD and EMCOT are going to the same places over and over again, just at different times to address the needs in a silo. It's a very expensive model for your city, but it's also really inefficient.
And so the Meadows recommendation is for CHPs to do the follow-up work. I think in the presentation that we just got, there was not additional funding for CHPs to be able to do that. Is there what is the sort of alternative that we're presenting here for the follow-ups?
The alternative is because most of those reports come through us.
Correct.
And with our current relationship with EMCOT, we're referring those follow-ups to the mental health clinicians to do. So we're basically taking the police out of the follow-up business, not including EMS, but giving it to integral care, to take mental health needs to the mentally ill person.
And of course, incredibly appreciate what Integral Care does, and I think we worked really hard on keeping EMCOT funding going after the loss of the waiver dollars. I would love to hear from you, Don, and then also a follow-up from you, Ms. Wagner, around what your thoughts are on what is proposed here about having EMCOT doing it versus community health paramedics doing it. What are the pros and cons there? How do we decide what the best form of follow-up is, since your recommendation was one thing, and then we have potentially another alternative here on the table?
Right. Thank you for your question. Actually, we are doing that currently. And I think it's not highlighted in this report per se because it was really focusing on APD's response to mental health. But we do currently co-respond with our EMS partners, or they'll be out on the scene and realize once they medically clear that individual and there's mental health issues, we are dispatched through 911, which releases EMS. We do some follow-up with them, especially if we're out in the field doing one of the follow-ups that come through our CIT referral process, and we realize that there are medical complications because, many times there are, like BJ was speaking. We do offer that integrated behavioral health and primary care at our outpatient clinic, so our clinicians are trained to do a part of their assessment and screening is also looking at those health indicators as well. And when indicated, we reach out to our host teams that are already out, or it's a direct connection to the paramedics under Andy, and I'll let you expand on that.
Sure. So the community health paramedic team obviously will work closely with Integral Care, and it is not unusual that if they're out on an individual follow-up or otherwise, that they have a direct link to us. They know how to get a hold of us. And so really it's whenever there's a medical need that either urgent, if it's an emergent situation, then obviously they call 911 and then they get an ambulance and an emergency response. However, for those non-emergent situations where there's a chronic or ongoing issue, it's not unusual for them to give us a call and request us either to the scene, or they'll staff the situation with us and we'll be able to send a paramedic out from the CHP team as a follow-up, either co-respond with them or we'll follow up afterwards, especially for those situations where there's no indication for violence or anything like that.
So, Ms. Wagner, what is, in your view, the difference between the recommendations that you've made and what we're presenting here?
It really boils down to formalizing that effort so that you're not spending the same dollar on the same person in 3 different places 3 different times. I think Integral Care, EMS, and APD should be commended for their collaborative efforts. I said many times in our work group meetings that this kind of informal collaboration where people want to truly work together is rarely seen, and it's highly valued. But the problem with that comes with they do it based on their relationships rather than based on a formal understanding, which in turn could lead to an overexpense of your precious resources. So if that response was formalized with some specific understandings and some specific collaboration and consistency across the clientele base, then perhaps you reduce the wasteful overuse or even the sad underuse of these precious resources. So they're doing it very well in pockets, and it's wonderful to see and should be an example for others. But if it were formalized, it would be more efficient and probably more effective.
And I guess my question is, if we are then dispatching EMS or Integral Care to more calls because at the 911 call center we are better capturing what are mental health calls that aren't dangerous, then I assume we then have more follow-ups. And if we're then going to have more follow-ups, but currently there isn't in here that we're going to have more community health paramedics or EMCOT folks to do those follow-ups, then are we going to create a pipeline where we don't have the end point of the follow-ups? And so I guess my question is, if this all works, are we going to need more CHPs and Integral Care folks to do that follow-up work that's oftentimes currently being done by 4 or 5 agencies co-responding?
Our capacity study actually indicated the opposite, that if you formalize your efforts and solidify them with what these three guys are doing now, it reduces that inefficiency. But also that's the key reason that there's a strong recommendation for the use of telehealth medicine in EMS, APD, and EMCOT, or linking them back to EMCOT. You can't hire your way out of this. You can't hire enough clinicians to blanket the city. But you can certainly put a solid number of clinicians in a telehealth center, and they can be anywhere in the city at any time and do follow-ups in people's homes, do follow-ups in the neighborhood, do follow-ups when a community paramedic is on scene and realizes this is a mental health client, and be available instantly. And then you save that precious in-person resource for those high acuity cases. So if you formalize your efforts, it'll increase the efficiency. And if you really strongly consider the adoption of telehealth, it's going to expand your reach tremendously.
I think the last point on that has just been that I've heard how stretched thin our CHPs really currently are. Right, they're coming for like a day or two a week north of the river, and then they have to go run back downtown or go here or go there. And I think that they're doing so. But it sounds like on the proactive work, we might consider expanding some of that work, and then maybe we just need to better drill down how those folks don't get stretched too thin if they're also helping with the follow-ups in a more formalized way. But that's useful to know. And then my third and final question was around first versus second responder, which I don't completely understand, and so maybe y'all can help us understand. But part of the question has been, how do we get clinicians, people with mental health expertise in that first response slot? That's what we heard a lot of the testimony and questions about last night. So help me understand whether this proposal gets us there, or if it's a step on the way there. How does this pair up on whether or not where mental health is the second responder versus the first responder?
That's the whole impetus behind the clinician and dispatch is when appropriate, when there's no report of violence or the threat of violence, to have a clinician respond instead of a police officer. So that, in those certain cases, with that clinician there on the floor making that determination, then we could absolutely have the clinicians be the first response in those cases, and limit the first response of police officers to when there is information in the call about the behavior of a person that's dangerous.
Okay, that's helpful. So it sounds to me like, thank you guys for entertaining this set of questions. It sounds to me like we need a bit of a huddle around whether the training that's being proposed can actually be done without cost, or if there's some better safe than sorry dollars that we just need to have to make sure that it works. If we're going to do it, let's get it done right. Second, Ms. Wagner, you mentioned that the most impactful thing you believe we can do is actually have the clinicians there at 911, and so we can sort of hash that out and decide whether or not we want to do that first or not. Third, there was this question that every major reduction you've seen in the expenditure of resources is when we do adequate and good follow-up. So let's just make sure we have that ironed out and formalized the way I think you've described, and we need to think about how we do that. And so thank you guys for laying this out and letting me run through that. But it sounds like there's still some small differences between what's in the recommendation and what's in the budget, and we just should just be really deliberate about those choices, whichever way it is that we go. So thank you.
Thank you.
You go first.
Well, thank you for that report. It's, I know that this services is badly needed in our community. What I want to know is what would include the expansion of the telehealth? Would that require more? It seemed like you're funding. Are we funding this already at 1.8 million? Is that in the budget, right?
Yes, sir. I'd like to start the conversation on that. That was a recommendation from Meadows, but just to kind of wrap up a little bit of the discussion prior is we actually do have protocols in place that kind of map how we respond, but we can tighten up those processes. I believe APD actually has policy on how they dispatch MCOT, and we do as well, so that we're not so we're more organized in our approach. But I think with this work that can help structure that a little further. We're currently piloting the telehealth recommendation using existing staff. We're using 2 of our mental health clinicians with 7 of the APD officers using 2 iPads that we purchased. And so this was just to kind of be prepared, provided there was funding available, if we wanted to expand that process, but really just trying to get the data right. So during the pilot process, is it doing the job that we want it to do? Is it increasing access to a mental health clinician in a timely way on the scene? Is it decreasing officer time on the scene and what their wait time for us, especially if we're going across the city in high traffic times where it takes twice as long to get there. And on average, we're seeing that it's utilizing the officer's time. The calls are lasting about 22 minutes, which is in stark contrast to what may be a 40-minute wait if they're waiting for us to drive out to where they are in the city. So that in and of itself, even at this very beginning stage, is saving time for the officers. It is a voluntary process, so the clients or consumers have to volunteer to this intervention, and give consent to do so. We're using a video conference platform that we currently use in our telepsychiatry services throughout our own internal outpatient services, which is HIPAA compliant and high trust certified, so it's nice and secure. But we are just using existing MCOT staff to run that pilot right now to try to gather some data. So if we want to scale it, if it's doing the things we want it to do, then we can come forward with a recommendation on what that would look like if we want to take it to scale.
I would like to see that recommendation.
Okay.
Thank you.
Yes, thank you, Councilmember Renteria. I would like to see that recommendation also. So a couple of questions. Just to follow up, can you give us that recommendation, I would like to consider it as part of this budget process. So I would like to have an understanding of this says about $1 million estimated for additional need to fund it. So is that for additional software, or is it for staffing, or both?
I believe the answer to that question is both. Okay. Primarily, the bulk of the cost is actually in personnel, as I guess you would expect. I think there's a little bit of room. We may be able to launch the service at not quite $1 million, because we have some existing software, so we wouldn't be having to purchase that. We could use what we're currently using and just expand those licensures. Just for instance, we would have to purchase some equipment. iPads are not that expensive, so they're more affordable now. So some of that cost would be lower.
The existing software, I would want to understand that. I would want to understand what it would cost to have the best practice as opposed to piecing together software. Now, I'm not saying you're piecing together software, but software that may not be geared toward this particular function, may not have the connection to all the data that's needed. You may be having to do some workarounds to get the connection to the data that you need. I would want to so what I want to understand in terms of the recommendations is what you need to put this best practice in place, because telehealth can really be a dollar saver.
Right.
So an initial investment in the right infrastructure, in the right software, is worth it, rather than. And I'm not suggesting you're piecing things together. It's just that. Using a tool that's HIPAA compliant that you can use for conferencing may not be the same as using a piece of software that is designed specifically to make that connection, particularly when you're wanting to do follow-up, and particularly when you're wanting to integrate with EMS and other services. Mm-hmm. So I would like to see a recommendation that really thinks in terms of what is it that you need.
Right.
Not what is it that you can get by with.
Right.
Not that you were saying that, but I just wanted to give you that parameter. Well, so I'd also like to ask BJ if you'd like to comment on what you think is needed as a best practice. Mm-hmm. And is there something there that may be in addition to what the pilot is doing right now?
Absolutely. And I want to start by saying first, it's critical when you're considering the addition of telehealth in the crisis space that you consider going beyond APD to EMS as well. Our recommendation is very specific for that, including areas of the city which indicate they have the greatest need for immediate connections, and you'll find that in some of the graphic mapping. But we are very specific that the technology should be, and we recommend connecting to Integral Care because they're the public provider and frankly the best provider of behavioral health in town, but should be connected between APD and EMS.
Okay.
And There's another large city who recently piloted telehealth, and for a while, for the first year, they used a specific mobile telehealth platform that provided for data collection, but also it allowed the clients who were served to download that app on their phones at home and to connect to their provider of choice at home through appointments through telehealth once they had been served through this system if needed, which addressed some barriers in this unique area of the state for transportation. For budget reasons, they left this software company, and when they did, they left all of their ability to mine and collect data behind and disconnected an array of clients from service. So if you have the ability to invest in quality software that includes data management, client connections, follow-up ability, and integrating into your electronic health record at Integral Care as well as EMS, and letting the team share that data cross-functionally from a paramedic to a police officer to a clinician, I would encourage you to consider that extra expenditure. There are several companies who do that. I'm not a commercial for any of them, but I'm happy to pass along just a generic list of names of people that you could reach out to and see the difference. But there is quite a difference when the data piece is integrated into the telehealth software, as well as allowing a shared record amongst providers. That continuity of care is key in this population.
Yes, and I think from Councilmember Renteria, I think you mentioned this, and others may have mentioned it too. There's a huge potential for greater efficiency, which translates into saving cost.
Exactly.
So I think your report may have this, but if not, if you have examples of how investing in this kind of infrastructure can save dollars, and where that's happened in other places, that would be helpful.
Sure.
Appreciate those comments. Manager, I would just say that as we look at budget priorities of things that are not in the budget, this would be my first priority, because I think it's real important for the city to do on so many different levels. I agree with Councilmember Kitchen, making sure that what we do as best we can, and really take a look at the long term, make sure we're doing best. And I will try to get up to speed as fast as I can on the different choices and the different proposals. We also have a precedent that we've done in past years where we say this is a priority and we put dollars aside for it, and then give you and the staff the ability to really take a look at what would be the best thing for us to do. And that might be appropriate here for us to put the money aside, but not over the next 3 weeks parse between us what is the specific plan. So I think that's an option we need to keep open, but this is a real priority for me as with others.
And Mayor, I wouldn't be opposed to figuring out all of these answers, some of the answers after the budget. What I don't want us to do is to provide way more dollars or way fewer dollars than the range of what we generally need. And so the only last question that came to mind during this last set of questions was, is it currently the proposal, how it is in the budget, that the mental health first response would be via telehealth, or is it that there would be a clinician as the mental health first response when it is one of these elevated situations?
So it's actually both. We're starting with the telehealth piece because it was the easiest piece to start, but clearly we're also on the path to get a clinician and have that protocol and pilot started as soon as we can get the equipment.
It's actually both, meaning the clinician would come online with no budget changes this fiscal year, or that would be for a future fiscal year?
I think the answer to that question is just scalability. Right now, we were just running the test. So we reached out to Houston, who has lifted a telehealth project and has been through many vendors. So I appreciate your comments, Councilmember Kitchen. You're spot on in making sure that we're utilizing the most appropriate tool. And so we modeled this telehealth project or pilot after what Houston did, and are using a similar tool that they're using as well. Just to keep in mind, we have also are in the transition of a new electronic health record that can do many of those things, having the patient have access to the data, being able to share data with first responders that we didn't have before. So I think those are all possibilities. And what we don't want to do is build a system where we have to have dual entry into two separate, because that just makes it more complicated and it takes longer, and then you have less time in the field. But currently, we've used existing EMCOT staff to just test that pilot based on Houston's best model. So if we're wanting to do the recommendations that Meadows is asking that we do, then there would be some additional staff to do those services in order to scale it in those particular time frames where there was a high level of call volume for mental health calls.
Understood. What I'm just trying to figure out is if this is a priority, if we were to change something to the budget, how much more scaling could we do this year? Because when I hear the answer that yes, we're doing both, but we're piloting both, I want to understand if there is more we could do. I don't want to skip over a pilot and scale something that's not ready to be scaled, but if there are things that are ready to go to a bigger scale, what does that look like and what does that take? So I just want to understand how much more we can do faster that is a good idea.
From a clinical perspective, I think Meadows' recommendations are spot on, and that's a good start for us to take a look at what that could look like and what impact we can make in Austin.
So what's the difference between their recommendation and what we have before us?
It would be essentially to take what's unfunded and fund those items.
And how much is that?
We can come back because there are some savings, as Don had mentioned, in terms of the software, depending on what they do in terms of getting the best practice approach to that. But we can certainly come back to that with that information.
Is that a software issue or the clinicians being there? So it's not just telehealth when there's a...
It would be a combination of all the things that we've been discussing today.
I think your highest cost is in personnel.
Yes.
Ms. Wagner, do you have off the top of your head, more or less, how much it is to get it so that when there's an emergent call, it's not just a screen, but there's the opportunity for a person when it's really important in the screen, when that's appropriate?
For the 2 clinicians in dispatch, you're looking at about $300,000, including fringe and equipment. To fully staff the EMCOT telehealth capability, you would want to add 2, maybe 3 more clinicians to that. I would have to look at my report to see whether we recommended 2 or 3.
I think it's 3.
3, but they also have to have an increase in perhaps prescription oversight or provider oversight. And Don said that they could probably bring that in-house. So at minimum, if you added the clinicians in dispatch at $300,000 and the additional 3 clinicians for the EMCOT telehealth capability, then that's $1.2 million. And if they're going to use their existing software platform, then you don't have any additional expenses there. So you want to make sure that you have enough bandwidth for those clinicians at $1.2 million, and then ensure that you can outfit and equip them by adding an extra $100,000 to that. And I would recommend at least providing integral care with enough funding. I think my original estimate was $150,000 to ensure that there's adequate clinical oversight of that additional clinical staff. So $1.5 million would probably get you the full program, including telehealth, clinical integration and dispatch, and the expansion of EMCOT to ensure that they were able to meet those needs.
But not the infrastructure, right? Not the best software potentially. That would be additional.
True. If you wanted to buy a software platform, I reached out to every company doing it to ensure that I wasn't a commercial. We are a nonpartisan, nonprofit. And every estimate was between $200,000 and $250,000 to do the software platform with an annual fee of around $50,000 a year for the subscription for the 3 companies. So your original investment would be pretty pricey, but the annual subscription fee would be pretty low. But if Integral Care can provide that same software with what they're doing now to include data integration and shared electronic health record, that's savings that you could really put into staff.
And so if we did all of that would fund your actual recommendations, and then we would actually have mental health clinicians as the first responders, but with police there to secure the area if necessary.
No, there'd be a clinician in dispatch triaging calls, but there's nothing in the plan that has clinicians responding as a first response.
Except through
telehealth.
Or I want to add to that. If we're in dispatch and we're taking the call and the risk has been assessed by the handoff from the 911 call taker to the clinician on the floor, that the risk is low and the mental health need is high, and we can dispatch, pull up in our own electronic health record and look to see, do we know this person? Have we responded before? Even if they're not open for services, we would have that data. And then we can dispatch through our own crisis services and through the system that we already have, either their care team or the mobile crisis outreach team directly. So that would put a clinician first on the response.
On the lower, so you're saying there would be a clinician as first response in the lower calls, but in calls where there's actually some potential danger, we currently do not have a plan outside of telehealth for there to be mental health clinicians as the response. Is that consensus on the table as the recommendation? That's the Meadows recommendation as
Agreed.
well?
Right. If anytime there's a public safety risk, you don't want to put civilians in the face of that. It creates an issue for the civilian's safety, but it also creates the potential for harm to the client that they're trying to serve, whether it be through a criminal charge that could have been avoided or any other situation.
And so it's not recommended as a first response, or what about as a co-response where you actually have police and the clinician at the same time? Or is the recommendation to not do that either?
The closest to the recommendation for that in the Austin report is integrating CIT into the host functions, or integrating CIT with the community paramedic follow-up. When we looked at quite frankly, I'm a fan of the little project I created in Dallas. I think it just won a national award for the Association of City Managers. I mean, I'm very proud of what that's doing, but it's very specific to the area that it serves in Dallas. It's been replicated in other areas across the state and in other states, Tulsa, Colorado, Washington. But again, it's very specific to those areas. I don't believe that multidisciplinary response team would be as effective in Austin as we've seen in other areas, just because Austin is a very specific community. So when we looked at what works, what does the community want, when we did all of the roundtable discussions and even looked at the types of behavioral health calls and the crises that's facing Austin with the demographics that are specific to your city, the recommendations that we came up with, as much as I tried to push them towards my favorite little model, just didn't make it there. Telehealth and infusing community health paramedics into the CIT team seemed like the very best option for what you're facing in Austin.
And this will get us that response during when we have the largest volume of calls?
Yes, that is exactly why you need to implement telehealth. You can be there immediately on scene if that iPad is in any police car or ambulance across the city. For instance, Project Ethan in Houston, the Houston Fire Department, has diverted over $2 million worth of clients from emergency departments for chronic use because they can immediately be on scene with an iPad and have that patient triaged for whatever comorbid need that they may be having, and the patient never has to leave their home to receive that service. We see the same thing through Harris County Sheriff's Office CERT team and through clinical dispatch anywhere in the country or state. But that telehealth expansion is what's going to get clients and citizens in Austin the immediate contact with a healthcare provider that they need.
Okay. We want to get to homelessness here in a little bit too. Natasha.
Yeah, I just had a couple quick questions. They're not necessarily related to the budget. I'm curious about the length of time for training for dispatchers. And you said something about console time earlier. So how long are they displaced from what their position would be? And then subsequent to the length of time for the training, I'd like to know how do the call takers demonstrate proficiency once they complete the training?
I would have to get you more information back on how they demonstrate proficiency, but the crisis communications class that they take is TCO mandated is 20 hours.
Allison, did you have more?
Yes.
Allison?
Thank you. I was just curious, if we were to proceed with this funding, how long would it take to be up and running? Because the numbers you're giving us are for a full year, and you wouldn't need to fund a full year at this point in time if it takes 3 months or 4 months to get the folks hired. And then also for the telehealth, it sounds like there would still be value in finishing out the pilot for a little bit longer before you made some decisions. And so the portion, the cost of the software would be the same, but the clinician's time that would need to be factored into this budget would be less. So how should we be thinking about that timing and its implications for the budget?
We can come back to you with that information. I mean, clearly, pilot has to finish out. The protocols have to be put in place with what we have in for existing resources, and then I think either 9 months or 6 months of funding. Again, we'll have to come back with some specifics in terms of the estimate that the team is working to.
And then I just wanted to make sure that I was understanding the part about the community health paramedics and Ms. Wagner's recommendations. So you're recommending that they do the part where they collaborate, but that doesn't necessarily mean that we need additional paramedics to enhance that collaboration. Is that what I'm hearing properly?
It's not popular, and I'm frequently not popular with some of my recommendations, but our capacity study, even including the follow-up function being added to CHP, didn't indicate a need for additional medics in that particular function.
Okay, was there another function related to this response where additional CHPs were needed?
Not in our study.
Okay, thank you.
Ann, you close this
Just,
out?
just one quick follow-up on the time frame. Ray, I'm not sure I understood what needs to happen first. Why did you say 6 or 9 months?
In terms of so that would
Yeah.
be in terms of funding,
Right.
additional, or when we could start funding once we identify what's required. I mean, I'm deferring. I initially said we'll come back with that information.
Oh,
I was
okay.
just estimating what the need might be, but we'll have to come back with specific information based on the actual work that they're doing in the pilot.
Okay, but I'm not certain. I want to understand from people, do y'all feel like the pilot needs to be finished? I mean, to my mind, I really don't want to slow down. I mean, we obviously are seeing results. We need some changes. So I think it's, if there's something that you all feel that needs to happen first, then I want to understand that. But I also want to let you all know that I think that I'm interested in getting beyond just studying and testing, particularly since I thought what I was hearing is that we already understand that particularly the clinicians as part of the triage, those 2 FTEs and the other things we talked about, we understand are important and expect to be useful. So perhaps what we're talking about is lead time to hire or train, but that's what I would want to understand. I'm not interested in more time to study if I'm hearing correctly that we're already saying that we think that this would be advantageous.
Right, I think that was the point of doing the pilot, so that we could be ready, provided that was your recommendation, that we could launch into that. So really, it would be the time around the hiring. We've worked out a large number of the policy and procedure for APD, so just adding EMS, of which we're just now starting, would not take that much more time to do.
Okay, thank you.
Dave?
Yeah, I just wanted to add that I'm also very interested in this kind of systematic change to our response. And so and I agree that if we're going to implement it, we need to do it right and not just do, little pieces. And so as we're talking about how we're allocating resources, there was significant discussion last night from the public about vacancies in APD. And so either now, if there's time to address that, or if it could be a budget question, to explain what appears to be a high amount of vacancies and whether those could be filled in this next budget year, and how the additional officers play into that.
And if you want those answers right now, I'll defer to Chief Manley and give him my spot. He has those
Sure.
answers for you.
That's okay? Okay.
Good morning, Brian Manley, Chief of Police. Specific to your question on staffing, as of this morning, we have 102 vacancies in the department. We have a cadet class that's running with 61 cadets in it as of right now. We do have a projection that has been put forward by our training and recruiting division based on improvements we've made. We've added 5 additional background investigators to our recruiting division so we can streamline one of the lengthier parts of the hiring process, and that is the background investigations and the vetting of our applicants prior to getting into the cadet class. I'll give you the shortest answer. The 30 positions that we're talking about in the budget this year, 6 of those, I'll remind you, are detective positions doing investigations to keep up with caseload. 4 of them are actually supervisors to handle span of control issues. So there's really 20 officer level positions that we're talking about in the budget. And when we look at the police staffing, part of it is we have to plan ahead. When our recruiting and hiring cycle runs from, on average, 9 months, they have to be in our budget so we know what we're recruiting for future classes. So the plan that we have right now, based on any plan you have, has assumptions built into it. And what we build in is the assumptions of average attrition rates, the assumptions of average start rates for class sizes that will get us to the staffing level that we need to be at based on authorized strength. So the vacancy rate in our department on average goes up between 5 and 6 per month due to retirements, resignations, or terminations. So when you balance all of that out, what we look at is the need for the positions in our budget this year so that we can hire them, start that hiring process through this budget year to hire them next year, because that's how it works. And then the addition to that also is, although we don't have the person filling the position, in other words, we don't have the officer filling that position, the need for that position exists. So oftentimes we are backfilling that position with an officer on overtime. So the funding is necessary as well. And then the last piece that I'll add is that the budget always anticipates that we will have positions that are vacant throughout the year, and that's why there is always a credit included in the police department's budget that goes against the salaries that we are given. And last year, I believe that credit amount was roughly $11 million. So it's already anticipated in our budget that we will have periods of time where positions are unfilled.
So I understand. I understand how you calculate and why you need to calculate the need, and how you do it based on attrition. But if those, I guess it's hard to, like, if the academy hasn't started yet. So you said how many are in the 61, and that's you still have the 102 vacancies. So those are just those aren't counted in the 102, right?
Correct.
Okay. So how long is the academy?
Our academy is 8 months long.
Okay, and so when will the next one start?
I can get you the schedule. Very early next year will be the next full class, and I believe we have a modified class that's going to start later this year. Modified class being bringing in the men and women that are serving as police officers in other qualifying police departments that we can bring here and train in a 4-month period instead of an 8-month period.
So is it possible that the class will be 102 people?
Is it possible? Yes. Is it likely? No.
Okay.
We've had classes in the 90s before, and what we end up with is, in those situations, we really split them in half, and we run like a red class, blue class, just because we don't want the student to teacher ratio to fall too far out of what we believe is a best practice. But what we've done with our plan also is we're looking at starting cadet classes basically every 16 weeks now, so that they will overlap so that we can catch up.
Okay.
We're also taking steps to address attrition rates in the academy. We have added additional tutoring for our cadets. One of the things I'm looking very much forward to is we just included a position out of the training academy for a training specialist. This will be a civilian who will have a background in the area of academia, who will hopefully ensure that, again, as we're teaching and training our cadets, that we're doing it in a way that, number one, best meets the needs and will best give them the materials, train them, but also that we are teaching that adult environment and in a way that we think will allow us to maintain and keep as many of the cadets. And we've included an entire resiliency component at the beginning of the academy now, just to kind of set them up for what to expect.
Okay, and so if the next class doesn't start till early January, and it'll take 8 months, that would take us into the next fiscal year, we wouldn't have even filled the 102 vacancies by the end of the next fiscal year. Is that right?
I will send. We've got a spreadsheet that we put together, and if it's of interest to council, then we can get that to you with these projections. And again, any projection is built with the assumptions of how many start the class and what attrition rate do we see through that class. But we do have projections that we've put together in anticipation of meeting our staffing goals.
Okay, yeah, that information would be helpful as we think about ways we're allocating our resources. So thank you.
Mayor, are we going to have a presentation by the police department?
Councilmember, we're happy to put something forward, and so I'll follow up
in the
with you
budget
afterward.
process, so we're going to have a discussion.
Say that one more time.
During the budget discussions that we're going to be having, is there one on public safety?
We're happy to take the feedback today and try to craft something for the next budget work session.
It sounds like there's a lot of questions that are going to be asked, and if we're going to follow this agenda that we're working on, you know, I would like to know whether I haven't done any kind of research at all on the police yet, so I thought maybe they were going to have some discussions later on, but I would love to have that report, that discussion on the budget also.
Yeah, I'm sorry. I didn't see one at plan, so that's why I used the opportunity because Chief was here. So I didn't want to take us off of our agenda, but I just thought it was an opportunity because I didn't know that if there was planned to have this discussion. So if there is going to be one, I'm happy to. I'm done asking my questions, but it looks like there's a couple more.
And I think that's good. And it would also help to identify the questions that you have in that area so that we would know. I bet it would be helpful for you to know how much time or what's the best way to answer those questions. Jimmy?
So it sounds like this might be kind of a wonky accounting question. As you mentioned, the vacancy savings line item that appears because we know we can't fill all of the positions within the next fiscal year. Does that end up being a one-time funds expenditure we're making in the current fiscal year, but by adding the FTEs, it's securing the ongoing for future budgets? It just feels like there's maybe some accounting happening here that's confusing.
I'm going to
It's
yield
more of
to
a budget
budget on
question,
that, but
yeah.
I just want to make sure I phrase it right. It's not in anticipation of not being able to hire the positions. It's just the realization that in any given month, when you attrit 5 or 6 a month, you don't immediately have the person to step in the next day and fill that position. So it's the realization that at any given time during the year, we will have vacant positions in the department.
But I think to Delia's point, which I tend to agree with, you know, what is the analysis behind adding FTEs into a budget when you know you can't fill them until the next budget? And so I'm trying to understand why we would do that. What it sounds like the reason is that it helps preserve ongoing future revenues for when you can hire them. But until you hire them, you have some one-time funds and other things that become available. And this just gets to be a very wonky budget accounting trick problem. But that does seem like what we're doing. And part of my questions that I would like to know is the supervisor positions that are added of the 30, how are those being allocated while we still haven't hired all the vacancies, and kind of what the triggers are for adding those supervisors as new people come into the force? I think the detectives are great. Definitely need the detectives. I'm glad that you mentioned the attrition in the classes. I was going to bring that up from the training academy. So you can have 60 in the class, but depending on what report you hear, it's 30 or 40 that maybe come out of it. I'm interested, once we get past this budget and we continue our ongoing, how do we look into the future, really exploring community service officers that were in the matrix report. That might be a way to get folks into the department at a lower requirement, get them into the less intense jobs and kind of put them in the field and let them kind of grow up into maybe a higher level service. I'd like to really explore that. It could also be cheaper, and you get more of them out there into the community. And it does sound like the chief is making a pretty strong argument for biennial budgeting. If we're making decisions right now on FTEs we can't hire till next year, then we may want to be starting to think about these decisions over a longer time period.
Allison?
So I just wanted to clarify, Councilmember Garza asked about the 61 in relation to the 102. And the 61 in the academy have to feed into that 102 when they finish, is that correct? Or is there a 61 on top of the 102 spots?
No, so if the class were to graduate today, then we would go to 41 vacancies. Does that clear that up?
And then,
Yes.
but you can't give people slots in an academy unless you have a spot for them to go at the end of the academy.
Correct. And that's why it's all based on projections. We have to project how many vacancies will exist the day that class graduates. And we've found ourselves in a position before where we were, 2 or 3 weeks out from a graduation, and we actually had one or two overage, where had they all graduated, we would have had an issue where we would have had overhired. And so we're not authorized to do an overhire like that. So it's always trying to hit that target of where will your vacancies be when a cadet class graduates.
And so built into your budget is this certain amount of vacancy savings per se, which is offset. So I think the calculations that we're asking for and really getting that clear is important, because I think there's some confusion over how this works. And I also want to underscore that there's still the need for the services of the police officers, which needs to be filled in that meantime. And so that also needs to be factored in. We can talk about where those resources are allocated and other kinds of things, but we are a growing city. And I do think that we need to keep that very much in mind. But I also, like my colleagues, welcome the clarity on the accounting part.
Greg?
All I wanted to elevate is for when we have that presentation, I think it would be really useful to see the calculations that you've put together based on sort of our current attrition rates and ability to, and percentage of classes that we fill. And then also if you're adding these resiliency components and doing things to reduce the attrition rate, I think that's a good thing because that saves us all time and resources. But to sort of have those side by side, if this year pans out at the current sort of attrition rates, how quickly we would fill it. If our attrition rate goes down, how quickly we would fill the classes. Having those side by side, I think, could be useful for us. So I think that's just one thing for whenever we get the spreadsheet or the future presentation that I think would be helpful. And then second, I would love to understand, again, it could be outside of this because I know we've got other items, the way that we decide whether we want to budget overtime staffing as in an overtime line item versus into positions, whether or not we're going to fill them this year. I just want to know sort of what procedure we use to know what budget line item we put each of those things into.
Mayor, and also would like to know how much overtime money we have spent in the last 2 years and how much time we're going to be estimating how much we're going to be spending this year.
Okay. Ann?
And just to add, there's also a difference between authorizing positions and actually putting the funding in this budget. We've done that in years past, a number of years past. What we did is we addressed the question of when the funding was actually needed by authorizing positions but not actually putting them in the budget until the point at which you needed the funds to spend. So I wanted to just point that out, that there's a difference between authorizing and actually and when the funds. It's just the same concept as we use for other FTEs, where we authorize the FTE, but we put 6 months or 3 months or whatever money in the budget for when they're actually going to be hired. So I want to have that conversation as part of when we lay all this out. So.
And I do believe the proposal does include that the detectives, there's the immediate need due to the caseloads, but the officers, I believe, might have been at a 6-month time frame. So I'll have to look at that.
Yes, but what's on the table is that these 30 officers, or the 20 or whichever it is, won't even come on board until next year. So the question might be, why put even 6 months in the budget right now? Why not authorize those positions, which sets us as authorizing them, but the money doesn't go into the budget until they actually start being paid. So anyway, I don't want to get us off, but that's a component of what we need to talk about when we have this presentation.
And as we go through, I don't understand quite all the machinations, but for me, I remain committed to the schedule that we had over a 4 or 5 year period of time of increasing the officers on the force. I don't know the right way to layer that in, but I hope we do that. I hope we do that on the timeline that we had talked about as we went through this a year ago and sent that path forward. That said, I'm conscious of the discussion we had yesterday, where a lot of people came up and said that mental health is really important to do, and they were indicating that we could find that money by not meeting that schedule. I really hope you can meet that schedule and still find somewhere the ability to do the mental health work, not as an either-or choice. I would really like to see us be able to do them both.
Councilmember Alter's follow-up question confused me because I understood it the other way. So the 102, I don't know the class, are those FTE vacancies, and are people in the cadet class not considered FTEs?
Yeah, so we have a separate category of 100, I believe it's 112 civilian positions because our cadets are not commissioned personnel yet.
Okay.
So they sit in those civilian positions while they're cadets, and then we transfer them into the commissioned FTEs upon graduation.
So you have 102 commissioned FTEs
Yes.
that will be filled, that, you said 60
One.
are in the cadet class. Those will fill so there will be 40-something left when this class graduates.
Correct.
And when do they graduate?
I'll get you the graduation date. I believe it's early January, but there will be more vacancies by then because, again, average attrition 4 to 5 per month.
Okay, thanks.
Okay, anything else before we move on? Yes, Paige.
Quickly, how do you calculate the total number of officers that you're aiming to have? Is it according to Austin population or, workforce resident ratio? Or how do you kind of find that magic number of who you're really expecting to need throughout a given year?
The shortest answer, the city for a long time had a way of approaching it as just 2 officers per 1,000, but that's not an appropriate metric because it doesn't address the real need. We focus on community engagement time, and that is the time officers have that they're not tied down to radio calls for service and other duties, but instead the time they actually have to engage with the community. And there are national averages and best practices, and at a minimum you should have 35% uncommitted community engagement time, and so that's what we strive to get to, is that 35% level. So we measure this on an ongoing basis. Back when we moved to this methodology, we had been as low as 17%. Right now we're in the low to mid-20s as far as our uncommitted and community engagement time. So we're pushing towards the mid and upper 20s, again with what we understand to be a national average, and what's out there is a minimum of 35% time.
Okay, that's helpful. Thanks.
Okay, anything else before we move on?